Ramon, you're breaking up. I couldn't hear the last part of what you said.
You can say something about your journey in time.
Sure. So, I'm originally from Visakhapatnam. Dad, granddad, both were ophthalmologists. Fortunately, did not go down that route. So, I studied actually medicine in Davanagere in Karnataka, and then worked for a year in UK, and then came on to the United States. I did my residency in internal medicine and pediatrics at Marshall University, and then endocrinology at the University of Mississippi Medical Center, and then stayed on here as faculty. So it's been about graduated in 2015, so about 10 years out of graduation, and actually enjoying it every minute.
Your dad's name, Vishnu?
I'm sorry, ma'am.
What's your father's name?
Prem Sagar, ma'am. My grandfather was Dr. Ramay Chetty.
Oh, very, very popular, ophthalmologist of Visakhapatnam for the last 50 years.
Yes, ma'am.
You didn't go into ophthalm?
No, sir. First year of medicine, I knew I could not be an ophthalmologist. I couldn't even dissect the body properly. Good thing I'm not into surgery.
Dr. Vishnu and everyone, I would like to, alert you, all of you, that we are already on YouTube. So we can start the session.
Amulya, good evening. Please go ahead.
Good evening, esteemed colleagues and guests. So I'm Dr. Amulya Alimenchi. I'm an endocrinologist from Vijayawada. It is my privilege to welcome you all today for this session on short stature being conducted by Endocrine Society of Andhra Pradesh. While short stature is common in our OPD, it presents a spectrum of diagnostic and therapeutic challenges. So our discussion aims to delve into the complexities of diagnosing and managing short stature while emphasizing the importance of early detection and comprehensive approach to care. So today we are honored to have with us Dr. Sanjay Kalra, sir. Sir, you are omnipresent everywhere in all the scientific sessions, so I don't think you require a formal introduction. But Dr. Kalra, sir, is an endocrinologist based at Bharati Hospital, Karnal, India. He has served as president of Endocrine Society of India and the South Asian Federation of Endocrine Societies. With over 2 decades of experience, Dr. Kalra has made significant contributions to clinical practice, research, and medical education in endocrinology. We are very honored to have you with us, sir. Sir, do you have any few words on today's session?
Thank you, Dr. Mulya, for that warm invitation. This warmth, friendship, fellowship I always get when I come to Andhra Pradesh. And though I live far away, I feel that I'm part of the state. We are actually inspired by the first Telugu poet, Nannaya Bhattaraka. What he tried to do, what Nannaya Bhattu tried to do, he tried to connect all languages together, and he tried to create unity in diversity. That is what Endocrine Society of Andhra Pradesh tries to do through its webinar series. We try to create unity in diversity. So our topic for today is short stature, something very important. If you don't have good stature, you cannot continue life, you cannot build a healthy life. And the Endocrine Society of Andhra Pradesh will get together different people from across the world, not only across the country, to speak about this. And the style that is being used is a very person-friendly style for learning because it is based on cases. So you share a case, you talk about it, you have people from different parts of the world sharing their experience, and this creates that strength which all of us get together. I am also reminded I don't know too much of Telugu. What I do remember, I learned from Dr. Nalini, Ek Pau Perugu, which is one pav of curd, prevents many diseases and promotes a lot of health. But another proverb I remember in Telugu is 1 plus 1 is equal to 11, not equal to 2. So that 1 plus 1 is equal to 11 is something that we will see on display today. And I thank you for making me part of the ESAP family.
Thank you, sir. We are also honored to have with us today two distinguished experts. Dr. Vijay Sarthi, sir, a renowned endocrinologist based in Bangalore. He is known for his extensive work in managing complex disorders of growth and pediatric endocrinology. We welcome you, sir. Vijay, sir.
Yes, thank you, Pa.
Yeah.
And also probably I would take this opportunity to thank Sir, Sanjay Sir. Indeed, just 2 years ago, he had given me an opportunity to write a chapter on short stature, that's disorders of growth in APA textbook of medicine. Thank you, sir.
We also have with us Dr. Srikanth Kongrasa, the founder and chief endocrinologist at Endolife Specialty Hospitals in Guntur, recognized for his contributions to endocrine care in Andhra Pradesh. We welcome you, sir. Sir, can you have us speak a few words about our case discussion today?
Yeah. Hello, sir. Dr. Kalra. Hi. So nice to see all of you. Good to have the presentation in this format. I'm happy to see the presentation and I've gone through this thing. It's a very interesting case. So I think without wasting much time, we can go on to the talk and then discuss about the cases at all. Okay.
Let us proceed with our first
Yeah.
case presentation, after which we'll open the floor for discussion and expert commentary. So the first case discussion is by Dr. Suhita ma'am from Kakinada.
Thank you, Amulya.
Yeah, please, ma'am. You can start the case.
तुम्हारे मोबाइल पे दिखाओ.
You can share your.
Is my screen audible?
Yes,
Is my screen visible?
Yes, ma'am, it's visible.
First of all, I would like to thank Ram Mohan and the entire ESAP team for conducting this innovative webinar series. Hello.
You're
Carry
audible,
on.
Dr.
Carry on.
Srikant. Please go ahead.
Is my screen clearly visible?
Yeah, it's
Yes,
visible,
but
but
you
please go
need
to
to
ma'am,
shift.
visible.
Okay.
But you have to shift to the slide mode.
Today's theme is short stature. I would like to start with the first case. This is the first case scenario. Here is a 3-year-old boy who was brought by the parents for not.
Dr. Suhita, so can you go to slideshow mode? I think for us it's not reflecting as a slideshow mode. Because
It
I
is
know
in
that
the
you have a lot of
slideshow mode only.
From current slide. Yes, do that. Click on this from current slide.
So coming to the first scenario, here is a 3-year-old boy brought by the parents for not growing in height notice since the end of the first year. He was brought to consanguineous parents as a full term spontaneously via vertex presentation. He is third in birth order with a birth weight of 2.5 kg. There is no history of any birth asphyxia or any delay in the milestones. His caloric intake was adequate according to the parents. There's no family history of any short stature or delayed puberty. His father's height is 172 centimeters and the mother's height is 162 centimeters. This is the usual scenario we come across a short child. How do we approach this child with short stature? Coming to the approach of the short stature briefly, whenever a child was brought with short stature, we quickly assess.
Ma'am, the slides are not moving.
Sorry.
Slides are not moving, Dr. Suhita. So
Ma'am,
it's still
can
not
you,
reflecting in the slideshow also. It's okay. Yeah, it's fine. At least keep doing this. Yes.
1 minute.
Ma'am, can you please click on the slideshow mode, which is present at the right corner at the bottom?
She has done it. Let us say from current slide. That probably would be good. Click on the from current slide.
Actually, it is in the slideshow mode only. Are you not able to see?
No, for us it's not reflecting.
No, ma'am.
1 minute. Sorry for the disturbance.
You can stop sharing and reshare, doctors.
Are you able to see now in the PowerPoint mode?
No, not yet. I think probably there is some technical glitch, Dr. Soita. No worries, but please ensure that when you go to next slide, you click on the next slide rather than going for a slideshow mode.
Okay,
It's okay.
shall
Whatever
I
we see.
do from
Please
here?
proceed. Please proceed.
Is this visible? Is this screen visible?
Screen
Screen is visible, ma'am.
Okay, okay. So whenever a child was brought with short stature, first of all, usually we'll be assessing whether really the child is short or not. In order to assess that, usually we need to take anthropometry appropriately, where height and weight should be recorded accurately, and it should be plotted on the growth chart. And then we need to take the maternal and paternal height, and then calculate the mid-parental height, and then plot it on the growth chart, and then assess accordingly. Always don't forget to ask for the parental pubertal timing, which is very important. After
One
that,
point I would
we
like
need
to
to
add
see
here,
whether
Dr.
the
Sweet, I want
child
to
is
add a
growing
point.
slowly or not. Hello?
Yeah, Dr. Sweet, I want to add a point here. Indeed,
Yes,
like
sir.
probably like many may not be aware of the new extended growth charts which are available. So earlier, whenever we had a short child who is slightly below the third centile, we were always confused whether it's below minus 2.5 or minus 3 or even more. But however, since we have an extended growth chart now, which is available by IAP now, our job has become easier. So I would suggest whenever you're evaluating a short child, always try to get the extended growth charts, where probably when you're assessing a short child, you know whether the child is severely short, or at least to know whether the child requires further evaluation or not. So because if it's a minus 2 to minus 2.5, most of the children will be normal variants of growth. Whereas when they have less than minus 2.5 or less than minus 3, more likely that they are actually one of the pathological short stature. So using these extended growth charts makes our life simpler in the recent days. Right, Dr. Sita, please carry on.
As pointed by Dr. Vijay sir, definitely, first of all, we need to plot the height and weight on the growth chart, and preferably the extended growth chart, and then proceed accordingly. If the child is really growing slowly, we need to further evaluate. Actually, single point height measurement is not accurate in assessing the short stature. Always better to have the growth velocity rather than the single point height.
Yes,
After that, we
Dr.
need.
Sumita, again, I want to add a point here. So when it comes to a growth velocity, we are always perplexed because we don't have any the pan-Indian applicable height velocity charts. But nevertheless, we do have growth velocity charts from Western India, given by Dr. Khadilkar, which we are still using for across the country. Of course, still the pan-Indian applicable charts are available. You can always use that. But the point also I want to highlight here is that like whenever we say slow growing or a reduced height velocity. So when it is less than third centile, yes, irrespective of the child's height SDS, it is abnormal. Even the child is in the within the normal SDS also. If somebody is growing, having a height velocity below the third centile is clearly abnormal. Whereas somebody who is actually having a height SDS between minus 2 to minus 2.5, already I'm looking at a child who is relatively shorter, who is more likely to be a normal variant of growth. But in that particular child, it becomes very important to understand whether this child is relatively growing slower. So what is that abnormality? What we commonly use is any child who is having a height SD of minus 2 to minus 3, but having a height velocity of less than 25th percentile should also be given due importance. Because if they follow the same centile, over the next few years, they are going to be into the pathological short stature. So that's why the height velocity centiles, where we call abnormal, differs for a child who is having a normal height SDS versus a child who is having a slightly lower height SDS. Probably we need to give importance for that sector.
So
Right, Dr.
always important to see if the child is really growing slow or not. And then we need to assess the body proportions. Always looking at the body proportions will directly give us clues towards certain etiologies like short limbs or short spine, and hence it's very important. Next, what all the work we are doing right now is to differentiate the normal variants from the pathological causes of short stature. So the normal variants of short stature being the familial short stature and the constitutional delay in growth and puberty. And then all this purpose is to treat the child where required and to alleviate the anxiety of both the child and the parents. And then coming to the case proper, there's no history such of any systemic illness or hypothyroidism or malabsorption or any visual field defects in the child. Anthropometry is weight is 6 kgs and height is 68 centimeters with a mid-parental height of 173.5 centimeters, and the target height range is 165 to 182 centimeters. We can clearly see that the height centile is pretty below the third centile, and even the weight centile is low, but height centile is much lower when compared to the weight centile.
So
Pulse rate.
what are the differential diagnosis we had to consider for this child? So somebody who has come with such a severe short stature, also weight being affected, maybe relatively lesser compared to height age. So before any investigations, what we could have thought?
When the height centile is more affected when compared to the weight centile, always we need to think about if the height centile is much severely affected when compared to weight centile. Always we need to think about endocrine disorders, especially growth hormone deficiency is more likely a cause, but though it's not a pathognomonic, it is one of the important endocrinological cause for severe short stature.
So, but probably hypothyroidism would be an etiology, but usually they will have a better weights. So,
usually their weight will not be low.
Whereas another group of conditions probably we have to entertain here would be primordial dwarfism, like the second group. So they also come similar to this with a severe short stature, with weight also affected, but not as severe as the height. Right, please go ahead.
And then the pulse rate and blood pressure was normal. On general examination, there is no pallor, any vitamin D, vitamin deficiency signs or jaundice. There is no goiter, there are no delayed deep tendon reflexes, and other systemic examination was normal. Before going into the case proper, just I would like to add few points about the famous ICP model by Kahlberg. It is the infancy, childhood, and puberty model. It describes the postnatal growth. It uses
Dr. Suhita, please go to next slide. Yes, you can see this. Please go.
Before going into the case proper, I would like to just describe the ICP model by Kahlberg, that is infancy, childhood, and puberty model. It determines the postnatal growth. It gives us clue regarding the etiology of the short stature. In the infancy, shortness is mainly because of maternal nutrition and fetal growth. Whereas during childhood, most of the common etiologies are growth hormone and thyroid hormone deficiency. Whereas during puberty, even sex steroids play a major role in the short stature. This picture depicts the height velocity. Actually, any individual will gain maximum height in the in utero, accounting for about 50 centimeters during in utero. And then the height velocity is about 25 centimeters in the first year. And from then onwards, there will be a gradual flattering to about ranging to about 4 to 6 centimeters in the childhood. Just before puberty, there will be a growth spurt, which is earlier in females when compared to males. Next, as Sir described, when a child approaches to us, we need to measure the height and weight of the individual. Is the screen visible?
It's visible, but not in the slideshow mode. But now the relevant slide is visible. You can speak.
Okay. So whenever the child approaches us, we need to measure and plot the height and weight. If the weight centile is less than the height centile, it indicates failure to thrive. Okay. We need. Huh?
That's an artifact, Dr. Sunita. You go ahead.
If the weight centile is less than the height centile, it indicates failure to thrive. And then we need to take caloric intake history and then consider evaluation of other disorders. If the height centile is below the weight centile, it indicates failure to grow, and we need to determine growth velocity and bone age for these individuals. If the bone age is equal to chronological age and the growth velocity is near normal, it indicates intrinsic shortness. The commonest etiology in this scenario is familial short stature. If the bone age is less than chronological age and the growth velocity is near normal, it indicates delayed growth, the common etiology being constitutional delay of growth and puberty. If the bone age is less than chronological age with subnormal growth velocity, we need to think about attenuated growth. Endocrine disorders come into play at this point.
So indeed, like before even coming to this chart, we need to do one more important step. So that is classifying them into proportionate and disproportionate. So probably there we can exclude a big chunk of disproportionate short stature. And when we are approaching to this algorithm, we are actually approaching only children with proportionate short stature. It's a very
Yes.
good approach. Yes.
And then coming to the case proper. And then coming to the case proper, on evaluation, complete blood picture, renal function test, liver function test, urine routines, calcium profile, and ABG are normal for this child. Surprisingly, during his routine investigations, we found to have RBS of 34 milligram per deciliter, which is a sudden surprise. How often, sir, Vijay sir, how often do you see hypoglycemia in a child with short stature? Is it quite common?
Very unusual usually. So maybe 1% to 2% of children with short stature only will have hypoglycemia of variable etiology. But 98% usually will not have any hypoglycemia. But before we go to hypoglycemia, so listing out the investigations required for a systemic evaluation. So it's also important that if, especially if the child is from North India, that we are ruling out a celiac disease. So, and also whether it was bone age was done.
Actually, I forgot to tell one thing in the history. He was third in birth order, as I highlighted in the history. The first two siblings being a girl child, and this third sibling is third child is a male boy. The parents were very particular about his height since beginning. So when they had noticed flattering of his height at length at 1 year of age, they started roaming around. And actually, all these ABG, calcium profile, urine routines, everything were done outside. By the age of 3 years, when he came to me, he was with all these reports. I was surprised to see there was only one RBS report, which was almost like a random report, and it was somewhere around 60 milligram per deciliter. This was the first point where we found that RBS is low. And actually, initially, I thought that that report might be wrong because the child is very active in the OPD at the age of 3 years. There was no history such of any early morning dizziness or any seizure attacks or anything in the past. So when we repeated, it was again reported to be low.
Right. So then we have a condition then probably where the child is short, not doing very well in terms of weight as well. But now we have only one abnormality, that is an random blood glucose of 34 milligram per deciliter. So in that scenario, what are the DDs we could have had? What all it came to your mind probably?
Actually, when we see a short stature with maybe if the weight centile is high and hypoglycemia is there, first point that would strike would be inborn errors of metabolism.
Inborn errors of metabolism can also fail to thrive. It's not that they do very well. So because
But usually most of them will be like these glycogen storage disorders, they will be like a bit plumpy.
yes, so some children will be plumpy. In fact, their plumpiness is just only in the face and the tummy. But if you take their weight, they may not be very plumpy actually, because they do have that Cushingoid appearance, chubbiness kind of a thing. But usually their weight will be lower. But there are many other IEMs. It's not only glycogen storage disorders. Of course, glycogen storage disorders, if we examine the abdomen, that would have given a clue, including hereditary
There was no
hypertension.
hepatosplenomegaly in this scenario.
Very good. So that's a point to note that we should examine for hepatosplenomegaly whenever we have a short hypoglycemic child. even gluconeogenetic disorders can do this. For example, phosphoenol pyruvate kinase deficiency can also present with failure to thrive with hypoglycemia. That is a possibility. Even in our Russell Silvers can present with hypoglycemia and short stature because of the IGF-1 activity is more in them. So that's one DD. So, and also any kind of a severe sickness, even if like a chronic liver disease or some etiology. So even if they're not uncommon for them to have, especially when they're not having adequate carbohydrate intake, it can also come with a hypoglycemia. So probably we need to have a little wider DDs to start with. But anyhow, so you have got a diagnosis. That's the lovely thing in the next investigation.
Actually, in this scenario, the child was not at all sick throughout, sir. The first point is he was very active throughout. Only because of short length, parents visited to multiple hospitals and was evaluated multiple times. But throughout, he was very active and very cooperative. So less likely to have glycogen storage disorders. If it is glycogen storage disorder or any gluconeogenesis disorder, usually child will not be so active and the failure to thrive will be more evident.
No, it's again a spectrum, Dr. Savita. In fact, like we had a 16-year-old girl who came to us with a glycogen storage disorder and hypoglycemia for the first time. So with a massive hepatosplenomegaly. Otherwise, in fact, she was diagnosed as a growth hormone deficiency and sent to us for growth hormone therapy.
Okay.
So it's a very complete spectrum actually. So in
Okay.
fact, even carbohydrate glycosylation disorders, they will also have hypertonia, inverted nipples, and hypoglycemia. They also fail to thrive. So yes, probably the good, like appearance or a lack of sick feeling can favor a possibility of MPHD. But the spectrum of all other disorders needs to be kept in mind when we start evaluating that.
Hmm. And actually, even the reports were correlating with the growth hormone reports, sir. At the point of hypoglycemia, GH is zero point 0.9 nanogram per ml and basal cortisol is 6.4 microgram per deciliter. The bone age of the child is in between 1 to 1.5 years, and the thyroid was euthyroid.
Yeah.
Actually, I have not gone for IGF-1 in this child because as the age is less than 5 years, IGF-1 is inappropriate. IGF-1 results will be inappropriate in this scenario.
But there is again some small concern there, Dr. Suhita, is the child who has a recurrent hypoglycemia, even if they have an intact hypothalamic pituitary axis, their response in terms of cortisol and GH may get blunted. So, for example, if you have a congenital hyperinsulinism child also, and you do a cortisol and a GH, it's not unusual to get these kind of values. So, whenever you're interpreting cortisol and GH in a case of hyperinsulinism, we need to be very careful actually. So, these values may not be considered like outrightly abnormal kind of a thing because it may be just a blunting of normal response to recurrent hypoglycemias. Because one episode, pituitary response, second episode, pituitary response, third episode, it may not respond. So that's something which we have to keep in mind. So even though IGF-1 could not be done, or probably you thought it was not an ideal test, so IGF-BP3 could have been a better choice. Because based on cortisol and GH, I will be little hesitant to make a diagnosis of growth hormone deficiency or multiple pituitary hormone deficiency here. And in fact, if you look at the current IGF-1 assays, fortunately, like when we used to do 10 years ago, they used to give IGF-1 as less than 25. But current assays, what we are using, they have a assay sensitivity of 11 nanogram per ml. So definitely, if even 3-year child, if it says less than 11, then I know it is actually low. So could have been a very useful to even do IGF-1. But of course, I don't know when was this case, but at least there's a recent
Actually,
case
this child presented to me almost 3 years back.
3 years back. So, but probably at least a year after, if we get any cases, IGF-1 can be done even in 2 years, 3 years, because our assay sensitivity has come down now. The important point probably where we have to be a little careful here is hypoglycemia and hypopituitarism. There are also some genes which can have simultaneously both disorders. So it's very common that yes, growth hormone deficiency or MPHD can cause hypoglycemia in the neonatal period, that we accept very well. But somebody coming to us at the 3 years of age coming to us with hypoglycemia. So we need to be a little skeptical to just make a diagnosis of MPHD. But always look for something more in addition to it. For example, we have FOXA2 mutation, where hyperinsulinism and hypopituitarism coexist. Even Kabuki syndrome can do that. So hypopituitarism.
But even their weight will not be affected much, right, sir?
Kabuki will usually be relatively good, but FOXA2 is again a variable spectrum. They can have a lean weight to normal weight kind of a thing. Because anyhow, it's a hypopituitarism is coexisting. Whatever this patient has because of hypopituitarism, there also you can have along with hypopituitarism and hyperinsulinism.
Actually, even I did not proceed for growth hormone provocative test in this child because according to the classical description that whenever a child presents with criteria of short stature with severe short stature fitting into oxological criteria for short stature, and when the child has one more additional pituitary hormone deficiency, and in that scenario, actually, it should have a major MRI abnormality. But here, he had only mild pituitary hypoplasia, except for that the location utopic pituitary with normal posterior pituitary. But he had only minor variation like pituitary hypoplasia is there. Hence, I have not proceeded for growth hormone provocative testing in this child.
No, I would say probably growth hormone provocative testing could have been avoided, not an issue, especially insulin tolerance that we don't want to do here. So clonidine can be done anytime after 3 years. Even glucagon I don't want to do because the child has spontaneous hypoglycemia also.
Actually,
But,
before RBS was reported to be low, I was thinking whether to do like clonidine is a bit tough to do in this child. So I thought like whether to do ITT, is it practical or not? It would be risky. So I was
I
thinking.
would be cautioning against safety of any of these stimulation tests, that maybe clonidine, maybe glucagon, or it may be insulin. In a hypoglycemic child, definitely they may not be very safe. But definitely, I would have done an IGF-1 or IGF-BP3 to strengthen my diagnosis. And also, I would have repeated a morning cortisol with an ACT stimulation test to double confirm there's a cortisol deficiency. So these two things I would have done to strengthen the diagnosis of
Sir,
hypothyroidism.
one more scenario. I will explain as I proceed. Actually, this child has once it was diagnosed to have the child is having GH deficiency and hypocortisolism. Before we could procure growth hormone, we started him on steroids alone at that point. So even after initiating steroid, the glucose levels were only slightly improved. Almost it was somewhere around 50, 55 like that.
Okay.
Throughout the course. And then actually,
usually it should improve well, because we, at least as we understand the physiology, isolated growth hormone deficiency can cause hypoglycemia only in the neutral period. Whereas cortisol deficiency is a MPHD, yes, to some extent, even later occurrences of hypoglycemia may be there. But we would have expected a much better improvement in glucose levels with hydrocortisone replacement alone. But of course,
actually, if it is isolated, if the hypoglycemia is because of hypocortisolism, definitely after initiating hydrocortisone, definitely it must have rise much. But actually, I guess like here GH is also playing a major role.
could be. So possibility is there, though it's a little unusual for the usual scenarios.
With these
Fine.
points, we thought like it is of multiple pituitary hormone deficiencies, and then actually after educating about the importance of providing good nutrition and promoting psychosocial environment, we started him on recombinant human growth hormone at a rate of 25 micrograms per kg per day. And along with it, hydrocortisone was started at about 12.5 milligram per meter square in 3 divided doses. At the end of 1 year of therapy, there was a height gain of around 11.5 centimeters in this child. And after 19 months of therapy, the height is 84.5 centimeters with an increment of about 5 centimeters in a span of 7 months. We could clearly see in this picture with the treatment, actually it is almost trying to reach towards the third centile line. We can
Right.
see from here.
Definitely. I think the response to treatment is very reassuring that the diagnosis was NPHD.
At this point, I would like to tell one more thing. Actually, after say about 12 plus 7, After this 19 months of therapy, he was lost to follow-up. Actually, his parents were working in Hyderabad, so he moved there. After a year or so, I heard from a pediatrician. She called me stating that this child previously who you treated was admitted with us. She mentioned that he had landed in severe crisis there. Actually, the thing is that they attended some function or something, and he had severe gastroenteritis, for which they had like ignored, and hence finally he landed in severe crisis, requiring ICU admission for about a week or so, which costed him hugely. And later on, even they stopped giving growth hormone therapy. Right now, he is 6 years of age, but because of financial constraints, they stopped taking GH. Only they were continuing hydrocortisone, despite they know the importance of GH in him. They were trying to work out on it. So definitely we can say that he has hypocortisolism, undoubtedly.
Yes, but this episode also he had hypoglycemia when he admitted again during the crisis.
Actually, there she have not mentioned me about hypoglycemia. She typically said that he had severe crisis because of cortisol deficiency.
So probably they did not know how to increase the hydrocortisone dose.
Actually, I have explained him about increasing the dose during stress, but the thing is that they were busy in a marriage, and so they have neglected him at that point of time.
Should have missed also.
Unfortunately, he had GE at that point. It's really unlucky.
Right, Dr. Suhita. I think it's a very good case, interesting case, a bit unusual as well. So
next, I would like to proceed to the second case.
right, good.
1 minute.
So you can have any comments from Sanjay sir or Maithili ma'am?
Coming to the second case, here is a 15-year-old boy. He was brought by the parents with chief concern regarding short stature and poor secondary sexual characters. He was born to non-consanguineous parents with a birth weight of 2 kg, born as late preterm. He had attained milestones normally. 1 year back, he was evaluated outside for short stature, where he was diagnosed to have subclinical hypothyroidism.
Ma'am, 1 minute. Shall I share? I have your PPT. Shall I share it from my end?
That will be good, Amulya.
Okay.
Just a second.
So was insulin not measured during that first child's hypoglycemia episode, Dr. Suhita?
No, sir. We have not measured hypoglycemia.
So we are preoccupied with growth hormone deficiency then.
Yeah, because he's having typical faces.
Okay.
Here is a 15-year-old boy brought by the parents with the chief concern regarding short stature and poor secondary sexual characters. Actually, 1 year back, he was evaluated outside for short stature. At that point, he was diagnosed to have subclinical hypothyroidism with an initial TSH of around 10.63. According to the history by parents, he was tested for GH provocative testing there with clonidine. According to him, he had severe giddiness with postural hypertension, which required IV fluid. And somehow they discontinued further follow-up, and hence growth hormone was not initiated. One more thing is that they could not afford it, and other thing is that they were unhappy with that postural giddiness. At the point where they brought him to me, he was 15-year-old. Weight is 34 kg, height is 137 centimeters, and the sexual maturity rating is A1 P1 with a testicular volume of around 2 to 3 ml. There is family history of delayed puberty, both in the father and on the maternal side to the maternal uncle. Father's height is 165 centimeters and mother's height is 156 centimeters.
So the previous evaluation was all normal. The systemic evaluation was normal.
A systemic examination was normal.
Okay. Fine. Go ahead.
Actually, at the point of presentation, both height and weight were reduced. Height, as usual, height is more affected when compared to weight. So even this case comes into failure to grow rather than failure to thrive.
Okay.
So at this point of time, because of as the child is 15 years old with features of poor pubertal signs, so we thought of child is having hypogonadotrophic hypogonadism, might be GH deficiency plus minus, because clonidine stimulation test he was mentioning like it was not totally low, but it was subnormal. So at this point of time, it could be either because of multiple pituitary hormone deficiencies or constitutional delay in growth and puberty.
So if you go clinically, see, like obviously MPHD or GHD with hypo, they are same. So we'll
Yeah.
take MPHD as the first DD there, what you want to entertain.
Hmm.
But to come to whether to diagnose of a CDGP or to diagnose of an MPHD, so we have to look for many other investigations. So whether it may be a systemic evaluation, a bone age at least will be required.
Bone age is between 13 to 14 years at presentation. Base of the first metacarpal led to be fused.
Okay. So 13 to 14 is not a typical of CDGP.
Actually, it looks quite unusual, because at the age of 13 to 14 years, at least slight pure must start, but actually he has even P1 at that point of time.
So one reassuring for CDGP in the history was a similar delay. Whereas probably if you say it's a 3 ml testicular volume, that was also probably a bit reassuring to me to say yes, it
Yes.
was there. And but of course, if there was investigations were not revealing anything like in the systemic evaluation, then when they did a chlorine stimulation test, probably one more history we have to elicit is whether they had used the sex steroid priming or not. So, but if they
Yes.
have done a only chlorine stimulation without a sex steroid priming, obviously that can give a falsely low value. So, had they used a steroid priming before the chlorine stim?
Actually, father said that they had given some treatment prior to doing that stimulation test. So definitely, I thought that he was given testosterone.
Right.
And
And
one
in fact,
more
like,
thing is that I had a doubt here. Actually, I feel like he typically fits into like a candidate for GH, because he had a birth weight of 2 kg. Though he was a late preterm, definitely 2 kg is definitely low. So we can think like IUGR at that point.
could be. Probably he could have been a better candidate to treat earlier, but probably not at the bone age of 14. So, but
Yes.
even if I start at 14, the window of growth is very minimal for him. But
Hmm.
yes, probably I would agree. Probably if the same thought was being given few years ago, yes, he was really could have been a candidate for a SGA who was failing to catch up. So again, if you look at the previous growth charts, that will tell clearly. And at this juncture of time, probably we need to again either wait and watch, or to give a testosterone priming was a question for you in January 2025. But why did you opt for a wait and watch without a testosterone
Actually,
priming?
I waited because um, one point is that he had subclinical hypothyroidism. Anyhow, we need to correct subclinical hypothyroidism. So I asked him to give levothyroxine. And one more thing is he's in 10th standard and he's staying in the hostel. So it's a peak time where it's tough to attend him. So I deferred it and asked them to review after completion of exams. So recently, when he visited me in April 25, his testicular volume had increased to 4 ml, and even the serum testosterone at that point was 66.2 nanogram per dl. There is a slight
Really?
increase, but disappointing point is that his height is 137.5 centimeters. Almost during this entire span of about 6 months, there is only hardly 0.5 centimeters height growth.
So one is probably we should have intervened at Dr. Ramakrishnan, can you ask him to mute all? Can you please mute all except Dr. Suhita? So the question is whether we could have given a testosterone priming at January 2025. So probably we have to look at the psychosocial impact on the child. If the child is getting affected, yes, I'm very short compared to others, or I'm all of them had developed some secondary sexual characters, because especially in a hostel children it's very common that
Hmm.
they also feel that the others have developed a secondary sexual characters but not we. But any such kind of a psychosocial impact is there, it's an indication for therapeutic intervention. But at the same time, probably sexual hypothyroidism of 10 of TSH need not have to be a contraindication for giving the therapeutic
Actually, it
treatment.
doesn't play a big role, but I asked them to I want
Probably the
to kill
second
some more
reason was
time.
genuine, but probably he was not able to take regular injections.
Hmm.
But in this scenario, again, somebody has a bone age of already around 14 years
Hmm.
or 13 to 14 years and short. So what would be your choice? Whether you want to give a testosterone priming or you want to give something different, which has been shown also some promise in hastening the puberty in CDGP patients.
I would prefer to give testosterone and then see whether it is CDGP
But
or not, whether the child has a lazy pituitary or not is my first option.
so it's true that probably the therapeutic intervention is required, especially the the bone age is less than 13. I would be more happy to give a testosterone
Yes.
priming here. So since the bone age is already 13 to 14, I would be more happy to give letrozole here, because letrozole also works similar to testosterone and has shown a good response in hastening the puberty in CDG. At the same time, it prevents the rapid maturation of the epiphysis, so that we may have some advantage in terms of height if we use letrozole or testosterone priming here. So probably personally I would have given letrozole for this patient since the bone age was 14. But what are the T3 and T4?
Actually, I did not order for free T3 and free T4. T4 that was done was normal. I guess it was somewhere around 8.
Because recently we had exactly similar clinical picture who came with TSH of around 6 and T4 of around 8
Actually,
and
T4 is 12 in this scenario.
is very good. Yes. So whereas our patient had a low normal T4, higher T3. So where
Hmm.
finally it turned out to be one of the TH receptor alpha mutation.
Okay.
So probably we need to pay attention for all three or T3 also, which we usually don't give importance to in short children. So it's very, very important even to look at the T3, especially if it's higher. We need to be a bit careful to rule out a THR alpha mutation.
Hmm.
And in fact, another point I missed in the previous case when we had a doubt whether it's a hypopituitarism or not. In fact, genital examination could have given a very important clue to
Actually,
you.
there is no short penis, sir, in that child.
Yes, one is short penis. Second thing is testicular volume, because we know that the mini puberty comes in the first 6 months. If there's a concomitant hypo, not necessarily it should be there, but if it had been there, testicular volume would have remained at 1 cc only. And if it's remaining at 1 cc and not 2 cc, then I'm more sure that what we are dealing with is actually panhypopituitarism. Though a 2 cc does not rule out hypopituitarism, at least it rules out a hypo. So probably that point was also important to look at the size of the testicular volume. Right, Dr. Sujita, please go ahead. You can go to the next case.
Actually, at this point of time, I was thinking to administer him testosterone for about 3 months and see whether any progress. If there is no progress, I was telling the parents that he might require gonadotropins at that point of time. What do you suggest, sir? What's your clinical?
Probably this is not a spectrum where we have to give a gonadotropin therapy. To give gonadotropin therapy, we have to have a clear diagnosis of hypogonadropic epilepsy. So when we are in a like dilemma situation to know whether it's a CDGP or a hypo.
No, not at that point of time. Once after labeling it like it's not CDGP, then we need to go for gonadotropin
It
therapy.
turns out to be an hypo.
Mm.
Yes, probably if it turns out to be an hypo, inducing puberty with gonadotropins is a relatively better choice than testosterone. But
Actually,
although
he had a testicular volume of 4 ml in this scenario. So definitely, I guess like if it is
probably
hypo,
no, he will be CDG because testo has come to 66. In fact, at this juncture also, I would be happy to add a letrozole to like enhance the puberty at the same time not having any greater impact on the maturation of the epiphysis. So that's what I would like to do for this child. If he responds well, I know it is a CDGP. If it doesn't respond well, yes, then comes a question whether its patient is a hypoid. And in that scenario, whether to give a induced puberty further with gonadotropins or with testosterone. If the patient is affordable, patient can ready to take like 3 to 4 injections in a week, and they're keen on the future fertility to be optimal. Yes, definitely go for a gonadotropin therapy. Somebody who is less affordable and not ready to take multiple injections, definitely go to testosterone therapy. Though there are several studies which have shown as kind of a relative benefit of gonadotropin therapy, that's still not proven. In fact, there is a recent trial by Dr. Ramamalia and PGI, so who showed that even when people had received testosterone therapy for 8 to 10 years, but later they received gonadotropin therapy for fertility induction, there was no significant difference between those who received testosterone versus those who did not receive testosterone priorly. So, in fact, it may not make a big difference. But given a choice, an affordable patient, somebody who is receptive for multiple injections, very keen on the future fertility, start with gonadotropin.
Thank you. Coming to the third case, actually, this is slightly a deviation from the current discussion. Actually, I thought to present this in this forum because she is a 6.5-year-old girl brought with features of early puberty during lockdown period. At her presentation,
So
I would like to, because these days most of the relatively short stature is because of early puberty. That's what I thought to bring this into discussion in today's forum. So during lockdown period, when she presented to me initially in November 2020, her height is 131 centimeters, which is more than 97 centile, and the weight is 26 kg. Mm, on testing, basal FSH is 4.1, LH is zero point 0.2, and E2 is 12. LH more than 0.1 is indicating of the child has entered into puberty, and then even E2 is collaborative to that finding, and then prolactin levels and thyroid levels were normal. At that point of time when the bone age was assessed, it was around 9 years. Pisiform has already appeared. Even it shows that there was significant progress in the growth. And then when ordered for ultrasound abdomen, the uterine volume is 2.7 cc. When the, can you go back?
Go back 2 slides. Go back this slide. I think probably you won't be able to go back. This is some problem in the.
Yeah, she had to.
Because even I had this problem. So go ahead. So basically, this was a girl who presented at 6.5 years with a breast development.
Yeah.
So, but the LH was only 0.2.
LH was 0.2, but E2 is already 12, and then bonus is 9 years, and then ultrasound abdomen showing like uterine volume of about 2.7 cc, even more than 1.8.
Maximum uterine length was less than 3.
Maximum length is less than 3.6 cm, but actually uterine volume is higher in this scenario.
Yes, there are some mixed features. It's not like that.
Yeah.
Is
Endometrial thickness also almost it has started. It was around 2 millimeters. We cannot comment on the ovarian volume.
Yeah, ovarian volume definitely we're not looking or giving importance to, but I'm giving importance to LH 0.2. E2 of 12 also we have to take it with very pinch of salt, because the assays what we have in India even in pre-pubertal children, it's not uncommon to have up to 20. So 12 is definitely not something very in the pre-pubertal range in Indian assay. So probably somebody is doing an LCMS and they're giving a value more than 5 also. Yes, it is high, but not for Indian assays. In fact, we have done a study on these pre-pubertal children. Even our assays have bounced, sometimes 8, sometimes 12, sometimes 16. So let us not take that as a very strong point to say it's a puberty. But of course, uterine volume is one important point, but uterine length is not favoring. ET is favoring. So even if she's in a puberty, she's in an early puberty. So then the question is whether she is going to be short at the end, whether we need to treat
Yes.
her.
Actually,
So
when I
because
ordered
nowadays
for
we have
MRI, at that point of time, the patient was not cooperative for sedation, and so the parents had deferred it. Actually, she was the only child, and the parents were very particular about her future height. Um, can you go
so
to next slide?
no, I think that will not stand.
So actually, at this point of time, almost it was like central precocious puberty, and likely etiology would be like idiopathic. When the predicted adult height was calculated, it was somewhere around 155 centimeters. Mother's height is 161. So she was very keen about shortness because all her cousins were somewhere around 55, 56. So she definitely wants a taller child.
Okay.
Whenever
Now,
there is a possibility,
yes,
though.
second point I want to discuss here, Dr. Sarita, is CPP. Yes, but is it a progressive CPP, non-progressive CPP? Probably looking at the
Actually,
CPP.
according to the history, they came to me at 6.5 years. It was lockdown period. So, according to the mother, the child had these symptoms for about an year before she was brought to me. The child was facing a lot of troubles when she was with peace because by that time, at the age of 5.5, she had axillary hair where she faced certain issues. So during lockdown, they could not meet any doctor, and so they were just waiting. So she
So what
came
was
to
the
me after a
what
year.
was the breast stage at presentation to you?
What, sir?
Breast stage. What was the breast stage at presentation to you?
It was almost 4, sir.
B4. Probably, yeah, B4 is definitely a progressive puberty. So in fact, without any history, B4 itself qualifies for a progressive puberty. But if it's a B2 or B3, probably we should wait and watch, especially with the kind of biochemistry you had. So LH0.2 is it of only 12. So it was a B2 or B3. It's good to wait and see whether she progresses. So if
One
only
more
it's a
point
progressive
at this juncture is that if we start GnRH analogs before 6 years of age, only then there will be an efficient result with respect to height. Already she had crossed that 6 years point, but she is still nearer to 6 than when compared to 8 years. So if we start therapy at this point, she will have some height gain when compared to after 6 to 7 months.
True. But again, like in fact, like also need to look at whether the bone age, what she had 11 years. What was her height age?
So actually, she was started on Liprodex in December 2020. She was
Okay.
a like compliant patient. She received injections every 3 monthly. This was after almost 3.5 years of therapy. When the bone age was assessed, it was 11 years. By then, sesamoid appeared. Initial bone age is 9 years.
9 years.
So,
When she was 9 years of age, what
when
was
she
her
was 6.5 years of
six
age,
and a
the
half years?
bonus
But what
is
was the
9 years.
Height age. What was the height age?
131 centimeters, sir.
So that,
So it's almost 97 centile. Might be in the next graph.
so like 100
Height
plus
is, if we calculate, it will be somewhere
24.
using to 6
In
plus.
fact, it's better than 9 years. It's almost like 9.5 years. So because 100 centimeter is equal to 4 years. After that, every year the child is supposed to
Age
grow.
into 6 plus 77. So if we take like 10 years, 10 into 6, 60,
So in fact, the height age is
60
better
plus.
than the bone. Okay.
Almost
So
equivalent to 9 years, sir.
it's fine. So even height age is equal to bone age also.
Oh.
There is a scope to wait and watch. So probably not necessarily that we have to hurry up for all these children, but there is a set of patients. Yes, we have to start where when the predicted adult height is going to be shorter unless we treat. So that's the group of children where probably we have to start on treatment.
You mean if the bone age and height age is correlating, no need to start at
I'm
that
just
juncture?
talking about particularly for this patient, Dr. Sunita, because this patient is quite young, especially if the pubertal onset was 5.5 years. There's no question of discussion here at all. You can start. But probably I understood your concern. Probably you want to know more on how to whether to treat or not to treat a child who comes with
Early
you know
puberty.
early puberty in the 7 years or 7.5 years.
Yeah.
Is the usual scenario what we are where career dilemma is. So in that scenario, if they are doing very well in terms of their height, especially height age is better than the bone age or at par, and we are doing using an expert, we are predicting what is the predicted adult height, which is going and reaching within the target height range. We can wait and watch, not an issue. In fact, there is a nice study published in Clinical Endocrinology in 2021. In fact, they analyzed the thing data. Yes, when there somebody is having pivotal onset after 8.3, there is no meaning in treating them. Whereas somebody who is less than 6.4 years, everybody should be treated. Whereas 6.4 to 8.3, they had a very clear data to say those who had a more advanced puberty or a more advanced epiphyseal maturation are the ones who probably had a difference in treatment. For example, they treated, then they had a better height gain compared to those who did not treat. Whereas those who had pubertal onset between 6.5 to 8, but their bone weight is only advanced by 1 year or same as this one, they did not get any benefit in terms of final height outcome. So probably what we can follow in clinical practice is treat everyone less than 6.5. More than 8, somebody is coming with the onset of development, don't treat.
No, yes.
6.5 to 8, those who have a more advanced puberty, more advanced bone age, consider them to treat for height benefit. Of course, psychosocial impact benefit is completely different, which we have to sit with them and discuss. What I'm talking now is actually for the height
benefit. Actually, after about 4 years of therapy, she had received her last dose in March 2025. Her current height is 152 centimeters. Uh, Slowly, she gained her height as of now. Definitely, there is an use of there is an use in using the GnRH analog at this point, because height is was advanced only by 2 years. There was a decrease in secondary sexual characters, and then again she gained about 20 centimeters, and still she had chances to grow in height. We need to see how she will grow in the next 1.5 year.
So currently, what's her age?
Her age is 10 years, 10 months, sir. And the
How
height
long?
is 152 centimeters.
Yeah, that's a good point. But like, how long you are going to continue lip price?
She decided to stop at this point.
Right. So 10
Because
years, 10
now almost she reached around 11 years.
11 years a good time to stop.
Yes.
Right.
So last slide. This is the last one. Actually, when Ramon asked me to present on short stature, actually I was keenly seeing which to be presented. That time I was concentrating more on height gains. Actually, it struck me. Actually, this is completely, totally different child. Actually, she was brought to me in September 2023 at the age of 15 years for Graves' disease. At that point of time, her height is 158 centimeters, and she had not attained minor. And in the next visit, they got with ultrasound abdomen. It showed like underdevelopment of uterus and ovaries for race. But actually, according to the parents, at that point of time, not attaining Minark was not a concern, because her paternal aunt had attained Minark at around 16 years of age. And finally, after 5 months or so, she attained Minark by March 2024 with a height of 161 centimeters. In the recent last visit after her inter exams, she came to me in April 2025, where her height is 165 centimeters. Here we can clearly show that CDGP cases do commonly exist in our community, and even a girl child can grow towards the end of intermediate. And the thing is that she had a sibling. That sibling is in 10th standard. She had not attained almost she had not attained secondary sexual characters. They were thinking about the same CDGP might be there even in that child. Have to look into that. point.
Yes, but hope the child doesn't have Graves.
Yeah, but actually she's right now 14 years, so I'm allowing her to one more visit. So maybe in the next 6 months, if she have not attained, we need to intervene.
And what about this breast development of this child? Because that
Actually,
will tell
she
me
had
whether I can
B3,
pick
sir,
it.
at presentation, but actually the child has Graves. One more point is in the Graves, usually they will be having advanced age and even the height will be higher. But for this child at 15 years of age, she was having still height potential. Might be severe CDGP is running in their family, might be.
No, probably they would probably would be take it as like a dilemma state. Yes, one could be
Hmm.
Graves' disease itself, which is
Hmm.
delaying puberty also. And though in general prepubertal children thyrotoxicosis causes a height gain, so
Hmm.
when it's offsetting the pubertal gain, so it may lead to short stature also. So again, Graves itself is could be a possibility that may be retarding the or slowing down the puberty. But looking at the strong family history of CDGP, yes, I would keep that also as a second differential diagnosis. And
Hmm.
especially the child
Actually, I
already
did
has.
not evaluated bone age and all in this child because their main concern is Graves at that point of time. And in the next follow-up itself, she had attained minor. So there I have not evaluated her with respect to short stature.
Yeah, probably one important point what you could have helped us is how did the breast development progress? For example, when she came to you in November 2023 or September
Hmm.
2023, probably where you could have asked us that how was the breast development the previous 1 year. So if it
Okay.
started almost 2 years ago but not progressed, again is a concern. But she
Hmm.
had developed a breast development only over the last 1 year and is already progressed to B3. Yes,
Okay.
that's a very reassuring thing for us to wait and watch. Yes, this
Right.
child will probably enter into puberty normally. No need to worry much or evaluate.
Okay. Thank you. Thank you all for giving me this wonderful opportunity. Thank you, sir, for sharing your experiences with us.
Thank you.
Thank you, Suhita ma'am, for sharing such wonderful cases and opening up the discussion. And thank you, Vijay sir, for such an insightful discussion. So, since we are, I think, lagging behind and we still have half an hour to go, Kalra sir, Srikanth sir, do you have any insights on these cases? Shall we proceed to the next case, sir? So, in view of time constraint, I would like to proceed to the second presenter, Dr. Vishnu Garla. He is an associate professor at the University of Mississippi Medical Center in Jackson, Mississippi. He serves as the associate division director for endocrinology, diabetes, and metabolism, and the director of the pituitary clinic. He is the principal investigator for several NIH grants and industry-sponsored clinical trials, and his research interests include neuroendocrinology and metabolic bone diseases. So, we welcome you to present the case, sir.
Can everyone hear me?
Yes, sir.
Thank you very much for this opportunity. Thank you, Dr. Kalra, Dr. Saradi, Dr. Srikanth, and Dr. Almanchi for this opportunity. Let me share my slides. Can you guys see my presentation?
Yes, sir.
My format is slightly different, so everyone please stop me. Please stop whenever there is a teaching point or if you need anything clarified. I would be more than happy to do that. Let's put this on slide. So I'm going to talk. So I primarily practice adult endocrinology, so we don't get to see short stature that often. But this was an interesting case which I saw a few years ago. So this was a 16-year-old white male patient who was initially seen by an outside endocrinologist with complaints of poor growth and short stature. He had also been recently diagnosed with hypertension and was started on clonidine for that. The history goes that he had grown poorly over the last few years and was the shortest boy in his class.
Yeah, Dr. Vishnu, I'm sorry to interrupt. So in fact,
Yes,
I
sir.
probably just wanted to run my thoughts on this. Like this patient actually had hypertension. They started on clonidine.
Yes,
So
sir.
whether it makes any difference to the height of the child, whether they probably all short children with hypertension should receive clonidine.
No,
Right.
I don't think it makes any difference to the height of the child.
Just a joke. I mean,
Age will
probably.
get the difference.
So because usually we do clonidine stimulation test, right? Every time we give clonidine, there is some amount of increase in growth hormone. And anyhow, if we have to give it for a hypertension, definitely true. It's not just for the reason of growth acceleration. We should not give. But when the patient has hypertension for some other reason, so probably whether is it worth trying clonidine as one of the first option of antihypertensive agent to promote growth. So just a thought process. Please proceed.
Yes, sir, that's very interesting. So again, pubertal changes were noted at 12 years of age, where he had onset of pubic and axillary hair. There was no history of any nausea, vomiting, polyuria, polydipsia. He did have diarrhea, which he said he had 3 times per day for over a year. There was no history of prematurity or delayed milestones. We didn't have any growth charts from his childhood to sort of look at. His height when he was first seen by endocrinology was 4'6".
Right.
His
So,
mom was, yes,
Dr.
yes, sir.
Vishnu, again, probably the point I wanted to make here is that so when there is an appearance of the pubic hair and axillary hair, so we may not consider them as a true pubertal signs. So because for us it's the gonadarche or the testicular enlargement is the one which actually heralds pubertal onset. And the appearance of pubic hair is more dependent on the adrenarche, and probably even in the HBG axis is completely abnormal. Even when then the children can have a pubic hair. So yes, it's a normal variant of puberty, if at all, if somebody has a premature pubarche, but usually it's not considered a pubertal sign or an onset of puberty. So, but anyhow, so it's the child had pubic hair at 12 years of age. That's a good point to know.
So mom's height was 5'1" and dad was 5'6". The only significant family history was maternal grandfather who had been diagnosed with osteogenesis imperfecta. The patient's initial exam gleaned from the records he had slightly webbed neck. He had hypodontia with only 2 incisors in the upper jaw. He had an extra finger postaxial polydactyly, and he had kyphosis of the thoracic spine. His genital exam did show he was stage 4 tanner per pubic hair with a normal testicular volume.
Normal, what did this normal testicular volume mean? Is it 2 ml?
Sir, this was from the record, sir, so I actually don't know exactly. They didn't give me a
Because
number.
that probably could have given us a clue. Anyhow, I have
Yeah.
gone through your case, so I know what the case is. So, but like since it is a Tanner stage 4, if it's a 2 ml testicular volume, so we had a clue for the diagnosis then and there itself actually. So because there will be few conditions where it can go for a P4 and with a 2 ml of testicular volume. And also probably important to know what happened to the genital growth, so the penile enlargement. So probably that could also add it to our understanding what's happening with the HPG axis. But probably they meant normal testicular volume is 2 cc is what I think.
So at this point, thyroid function test, growth hormone, IGF-1, bone age, and renin-aldo, metanephrine, ACTH, cortisol, these were all ordered for secondary hypertension, echocardiogram. I think at this point, the differential diagnosis they were looking at was Noonan syndrome, so they ordered a genetic evaluation for Noonan syndrome as well.
Now, why was the Noonan syndrome suspected? Because of web neck?
The webbed neck, and I think the hypodontia, hypertension. So I think at that point, that was one consideration they had. So genetic testing for Noonan syndrome was negative. Bone age was 15 years when the child was around 16 and a half years. The other, the renin, aldosterone, metanephrines were all normal. Echocardiogram did not show any abnormalities. ACTH was 37 and cortisol was like around 20.9. And I think this was done around 9:30 in the morning. So IGF-1 was 685, which was over the normal limit for that prescribed lab test.
Pretty elevated IGF-1.
Yes, sir.
So then probably again we need to go and look at the puberty again when was it more advanced. So we have not done any testosterone value, right? Anytime?
No, sir, not till this point there was no testosterone.
Because of course, in pivotal children it can go up to 900. So, but like this child seemed to be delayed puberty as well. So in that background, 685 is quite high. So, and having such high IGF-1 but short stature is little contradictory.
Yes.
No worries, please go ahead.
Yes, and growth hormone was 1.8. Again, going along with the IGF-1 was elevated. At this point, the patient was referred to us. So again, in between this, he had missed several appointments. So we saw him a year and a half later. In the interim period, he had actually been to the ER for kidney stones. He also had compression fractures of his thoracic and lumbar spine between T9 to L4. So when we saw him, his history was significant for acne, easy bruisability, increased body hair. His physical exam was pretty significant for buffalo hump, lipomastia, facial plethora, and dark stria on flanks, shoulders, and groin. So this was when we saw him 1.5 to 2 years later after he had seen the last endocrinologist. So he had nice buffalo hump, acne, and stria, which were looked pretty Cushingoid in nature. So there was very high suspicion for Cushing syndrome. ACTH and cortisol, when we measured it, were 70.8 and 32.6, which meant more in line with central cause of the ACTH, Cushing syndrome. 1 milligram dex suppression test, which we did, showed a cortisol of 26, and a 24-hour urinary cortisol was elevated more than 4-fold times or 5-fold times at 280.
And what is this assay for 24-hour free cortisol you had? Because it has a very narrow reference ranges. So is it an LCMS?
I think so, sir. Yes, this is we ship it out to Mayo Clinic, so I'm pretty sure it's LCMS.
Okay, then probably it's an LCMS, because usually what we use in India is more of a radio immunoassays or a CLIA. Usually we have quite higher reference ranges. Even the CLIA it's 110, whereas radio immunoassay we take up to 210. So I think probably if the 45 is the upper limit, it must be an. Right, please go ahead.
Yeah. So MRI pituitary was done, which did show a 6 mm hypoenhancement in the sella, which was again suspicious for a microadenoma. So he was referred to.
Go back, Dr. Vishnu. Yes. So this is actually not a adenoma what we are showing there. Probably we're missing the adenoma somewhere in some other image, because adenomas would never be so jet black. Usually jet black things are actually the phlovoids in blood vessels. So that probably what is shown, especially in the sagittal section, is actually a part of blood vessel. So even in the coronal section also, usually we don't see so much of jet black tumors. They will be usually hyperdense compared to rest of. Probably good to choose some other sequence where tumor can be better appreciated. But anyhow, so I saw the histopathology, they have taken out a tumor. Obviously, there must be a tumor and they might have resected the tumor completely. But probably this is not the tumor. And what was the tumor size? Because
6 millimeters.
Sorry, Dr. Vishnu?
6 millimeters. So it was
millimeters.
just at the threshold.
Yes, just at the threshold. So probably it's a 6 mm. Probably we can directly hand over to the neurosurgeon, so they can explore, but probably it's lesser than 5 mm. Yes, definitely we need to have more evidence to say it is a pituitary disease. But anyway, 6 mm, then you're right. You can go ahead.
So transsphenoid referred to neurosurgery, transsphenoidal resection was done, and pathology was consistent with the corticotroph adenoma. It stained positively with ACTH. So post-op, the ACTH levels were pretty low. ACTH and cortisol levels came down, and the patient was started on hydrocortisone. This was like 24 hours post-op.
Yes. So it's a cured patient.
Yes.
But like there comes again, probably if at all, if you're looking at our short statured part, what was the change in the height velocity after surgery? Because the remission also, because cortisol has come down to 1.9, 1.26. How did the puberty and growth progressed after surgery? Because it's very relevant for this patient.
Yes, sir. So we saw him 1 year after his 1 year after his surgery, sir. He again kept on missing several appointments, but he had grown 3 inches in that 1 year. So he went from 4'6" to 4'9", and his genital exam at that point
was he had complete pubic hair, penile enlargement. Now we didn't have a testicular volume before, so I don't know how to compare.
Yeah,
Again,
probably, ideally, I would have waited for at least around 4 to 6 months before making a diagnosis of hypogonadism.
Okay.
So at least if there's no change or no progression of testicular volume after 4 to 6 months after remission, yes, there's an indication probably we may need to make a diagnosis of a permanent hypogonadism and induced puberty. Otherwise, it's good to give some time for him to recover from the long-term hypercortisolism effect. Whereas it's also true for growth hormone axis. Yet, unfortunately, he has not received growth hormone and he has done well. I think he was 4.1 and he has come to 4.9, isn't it?
4.6.
4.6 to 4.9. So still almost 7.5 centimeter in a year.
Yes.
So it's definitely for a pre-pubertal age, it's good, but for a pubertal catch-up, it's not so good. So anyhow, since he already had a bone age of 15 years, again, even intervening at this child with growth hormone was not a very good option. But allowing spontaneous growth gain is only good. But probably this child would have been a very young child, like a 12-year or 11-year with a bone age is 10. And in that scenario, probably if they're not catching up well, it's not just the usual height velocity. When we cure or patients go for remission, if it's a young child, it should definitely catch up well. So even if they're not catching up, then we need to evaluate for a growth hormone deficiency. So and if there is a growth hormone deficiency is identified, so then probably we can definitely add growth hormone therapy. But I agree for this child, probably since the bone age was already 15 years, there was not much of a benefit of considering growth hormone therapy. So, and again, why was the MRI done after 1 year?
So here they generally do after 1 year, sir, to show for any recurrence or residual adenoma left.
Yes, probably this evaluation is more pertinent if at all if the child had a biochemical recurrence. So, or a biochemical evidence of hypercortisolism. If the child did not have a biochemical hypercortisolism or endogenous hypercortisolism, there is probably no need to do an MRI. But of course, I do agree that different hospitals have different protocols. Right.
Unfortunately, this patient was again lost to follow-up, so that's all we have on him. But it was a very interesting case for us, at least for Cushing's a disease resulting in short stature.
But indeed, it's very important to call the child back and ask because they are very prone for recurrence. Almost 20% recurrence rates are known in especially young Cushing patients. So over years, they definitely may come back. That's possibility is there. Right. Thank you so much. In fact, it's a very interesting case. It's in fact area of my interest. So thanks for presenting this, Dr. Vishnu.
Thank you very much. Thank you everyone for giving me the opportunity to present. Very nice to meet all of you.
Thank you, sir. Thank you for presenting the case. And once again, thank you, Vijay, sir, for leading us through the discussions. And we had a wonderful time learning from you. So to summarize today's case scenario, so we did have introduction of the extended growth charts, which not only has the 7 percentiles, but they also have the standard deviation point. So minus 2.25, minus 2.5, and minus 3, which will help our diagnosis of growth failures very easy. And for the second case, sir, Vijay sir, are you still there? Yes, sir. So for that case, because the bone age is not more is near the chronological age and he's nearing the puberty, so we can try letrozole instead of growth hormone, sir.
Instead of testosterone, because usually there are also the two options. We have testosterone priming and letrozole.
Okay, yes, sir.
Yeah. And you want to add growth hormone therapy on the top of that, especially when the predicted adult is going less than minus 2 SD, you can definitely consider that.
Yes, sir. So in that case, GNR letrozole plus growth hormone works better, sir.
Yes, that's a best choice if at all, especially if the patient can afford and the final predicted adult height is less than minus 2 SD.
Yes, sir. Yes. So because you have brought up the clonidine discussion, sir, so there are reports where, and I think they're practicing clinically as well, they're giving arginine for IUGR.
Supplementation. After birth, postnatally or prenatally?
Prenatally, sir. Okay. Prenatally. So will it have an effect postnatally as well, sir?
not much.
Okay, sir.
In fact, like for anything to work, we want intact somatotropes, so which have some receptors on them. So majority of the cases, they will not have somatotropes. So usually, even if you give clonidine or arginine, very unlikely to help. But there are some cases of a partial growth hormone deficiency where there may be some benefit. So that's
Maybe not in growth hormone, but in idiopathic short stature cases, will it have a role, sir?
even in idiopathic short stature, arginine did not have a role. Even clonidine doesn't have a role.
Okay. Thank you, sir. Thank you once again for giving our expert advice in all of the cases, sir.
Rama Mohan and my dear friend, of course, respected Maithili ma'am for giving this opportunity. So, and thank Dr. Sanjay sir and Dr. Shrikant sir for joining us. So, you can take over, Dr. Murli.
Thanks, Vijay. Thanks. We enjoyed your presence today. Thank you.
Thank you so much.
Thank you, Shrikant sir, and thank you, Sanjay Kalra sir, for accepting our invitation and for joining us. I think it's past 9:30, so we had a meaningful discussion today, and thank you, one and all. We'll end the show. Thank you.